So, in the thoracic spine, few things we'll be covering today. One is first let us talk about the spine. And then we'll be talking about few of the small tiny nerves. One of them first is this is your spinous process. You see spinous process. Spinous process is very superficial in the thoracic area. Just below the skin, you'll be able to see the spinous process. And then as you will be holding the probe in the long axis, just lateral to that will be sudden dip. And this area will be hosting the multifidus muscle, and above that there will be spinalis muscle. And then there is a curve. So this part is elevated till the transverse process, which is most elevated. So when we'll be holding the probe first, the most superficial will be the spinous process. Then there will be sudden dip. And here we'll be getting the interlaminar space area. Then if we are going still lateral, we'll be getting the facet joint area. Ultrasound guided facet joint injection is one of the procedure. And then we'll be getting, so facet joint, if we are asking where to inject the facet joint, till you'll be getting, these two bones are very close. If we are going little more lateral, then the transverse process slope will be starting on the either side. Again, this area, transverse process are very elevated, closer to the skin. So in this area, when we'll be getting the gap between the two bones, that means you are in the lateral edge of this. This is your superior articular process. This is the inferior articular process. So that means you are going to the lateral edge of that. As soon as the gap will be, soft tissue will be coming between these two. So then go slide little bit more again medially, and you'll be able to see this in the facet joint area. Facet joint area and interlaminar area sometimes might be confusing. Interlaminar area might be the more gap, but may not be shown in the lower area. Maybe the gap is almost similar. So if it is asked that where to inject for your facet area, the best thing is you just slide the probe more lateral. As soon as you'll be seeing that, okay, lateral edge, soft tissue is coming, then again go back to earlier place and you have to go for the injection there. Then if you are going more lateral, you understand this is the most elevated part and this is the most elevated part. And then if you are going more laterally, this is the costotransverse joint, this one. And here there is one ligament, and that ligament is the lateral costotransverse ligament. So there are two costotransverse ligament. One is superior costotransverse ligament. Superior costotransverse ligament is from one rib below to the above transverse process, like this, from here to here. Okay, let me draw so that you will be able to understand it better. So lateral costotransverse ligament is here, and superior costotransverse ligament is from this rib till this one. This is your lateral costotransverse ligament. And let me clear the drawing. So for the paravertebral block, we normally go there. Either you pierce the superior costotransverse ligament here obliquely out of plane, or you can come here. There is the membrane, that membrane you can pierce it. I'll be showing you and you can. Okay, so this is little bit about the bony anatomy, and coming to this is the thoracic area. I'll be talking about the lumbar area as well. In the lumbar area, almost similar, but here the interlaminar gap is much more. And the interlaminar area, you can easily find out this interlaminar space, and you can go into the epidural space, spinous injections easily. Thoracic area, it is difficult because the lamina are much more crowded. So in the lumbar area, normally you hold the probe first here, and then you'll be able to see the transverse process, short axis. If you're holding the probe like this, short axis, you'll be able to see that this as a small your hyperechoic lines, and below that there will be acoustic shadow, and in between this we'll be having the ITC. intertransverse complex. In the ITC, we will be having the intertransverse muscles, intertransverse ligaments, and also some of the blood vessels. Then when we'll be sliding the probe more medially, this area of the bone is most projected. I'm just magnifying it. You see, this is the superior process. In this superior process, the most lateral part is known as the mammillary process. And this projection is known as the accessory process. There is a ligament, mammallo-accessory ligament, below which the medial branch basically passes in this way. So in this mammallo-accessory ligament, the medial branch will be blocking, we'll be able to see that. And apart from that, when we are holding the probe from the transverse process view more towards the medially, we'll be able to see the mammillary process view. Suddenly, you'll be seeing that height is increasing because this mammillary process, you see, the most projected part, what I was telling, is the most projected part. So mammillary process view. And then when we are sliding little more medially, we'll be able to see in this area, that will be the articular process view. And still, if you are going more medial, will be coming here, that is the laminar view, also called the horsehead view. And if you are going more laterally, you'll be able to see the quadratus lumborum muscle. Quadratus lumborum muscles will be beyond this one. Okay, now let me put a little bit of muscles, and then again, I'll be going for the demonstrations. So if you're putting the different muscle there, let me put all the muscle layers. Okay, so here, another layer is there. So this muscle is, you can unmute yourself and you can, participate the discussions. So what is this muscle?
Trapezius.
Trapezius has the 3 band. Superior one, this one, then horizontal, and then let me remove this. This is the transverse part. This was the descending part, superior part, and this was the ascending part, that is the inferior part. Let me remove this trapezius. And then here, this is very important. Try to understand very carefully here. So this is your scapula, okay? So this scapula, this is the spine of the scapula, which is going to be the acromion here. And this is your claviculum. So this muscle is what muscle?
Supraspinatus.
Very good. So now the spine of the scapula, if you have removed the first layer of the muscle, that is your trapezius, at the level of the spine of the scapula, this is one muscle. What is this muscle? If anybody can say, muscle is your rhomboidus minor, and this is your rhomboidus major. So remember, at the level of the spine of the scapula, it is your rhomboidus minor, and below the spine of the scapula is your rhomboidus major, and this muscle is your levator scapulae. That means above the spine of the scapulae, this muscle is levator scapulae, rhomboidus minor, rhomboidus major, and all these are in the same plane below the trapezius. That means if you are holding the probe here, you can palpate easily the spine of the scapula. If you are palpating the spine of the scapula and holding the probe here, then below the trapezius, which muscle shall you see? You'll be seeing the levator scapula. If I am holding the probe here at the level of the spine of the scapula, below the trapezius, what I will see?
Rhomboid.
And below the spine of the scapula, if I'm holding the spine here, then below the trapezius, what I will see is a rhomboidus minor. Okay? Sorry, major. So all these 3 are in the same plane below the trapezius. Right? This is very important because in this plane, the one important nerve will come. That is your spinal accessory between the trapezius and these levator scapula. It will be coming just medial border of the scapula, and spinal accessory muscle is very important entrapment and can cause the pain here in this area. And trapezius myofascial pain many time is associated with the spinal accessory nerve entrapment. Okay, so below the trapezius, if you are finding some pulsating vessels, some black dots, understand that they are the spinal accessory nerve and accompanying blood vessel. So here, another thing to remember, what is the action of the spinal accessory nerve? Which muscles are supplied by the spinal accessory nerve? Anybody can say? the two muscles, trapezius and the sternocleidomastoid. So what are the functions of this? So they elevates the shoulder. Okay. So if there is palsy, so there will be sagging of the shoulder, particularly the trapezius. Sagging of the shoulder will be dropping down. Levator scapulae also elevates the shoulder a little bit, but trapezius is one of the major muscles, and if the spinal axillary palsy is there, there will be. Apart from that, the sternocleidomastoid muscle actions also might be jeopardized. But shoulder, if it is dropping down, you have to think, and if you are finding some myofascial trigger point in the area of the trapezius, you have to think for the spinal axillary. So now if you are removing below these layers of muscles, they are all the same layer, and the medial border of the scapula, the levator scapulae, the rhomboides minor, rhomboides major. If I am removing this, then this muscle is what? Who can say? This is your serratus posterior superior. There are two serratus posterior. Serratus anterior is here. Serratus posterior, one is here, another is below. So this is your serratus posterior superior. So then if I am removing this muscle also, then comes the posterior layer of the thoracolumbar fossa. If I am removing that thoracolumbar fossa, then these are your erectospinae group of muscles. Here in the lumbar area, is thoracic area, erectospinae group of muscles have most medial is your spinalis muscle. Below that spinalis is your multifidus muscles, then longissimus muscles and iliocostalis muscles. So basically here in the thoracic area, we are having the four muscles. Spinalis most medially, then your below the spinalis is your multifidus, then longissimus, iliocostalis. Okay. Talk again, recapitulate again with me. Most medially is your spinalis, below spinalis is your multifidus, the lateral to that is your longissimus, and still lateral to that is your iliocostalis. And this longissimus basically lies over the transverse process, tip of the transverse process. Okay, so this was the longissimus muscles. If I'm removing it, you see the tip of the transverse process are exposed. So when you'll be holding the probe, if you wish to identify each and every muscle layers of the erectospinae group of muscles, you remove the, you identify the just above the muscles, very bulky muscle is your longissimus, and medial to that is your two layers. One is your spinalis, below that is a multifidus, and lateral to that is your iliocostalis. Okay. So now come in the lumbar area, and after that you'll be having the rib and the intercostal muscle and then the pleura. Now come in the lumbar area. Let me remove the latissimus dorsi muscle. So here strap muscle is latissimus. These are the serratus posterior. Let me amplify it a little bit more. So here, what muscles we are having? Here the erectospinae group of muscles have the three. One is most medial is your, let me, put all these muscles. So latissimus dorsi, if you have thoracolumbar fossa, then latissimus dorsi, so removing that, then this is your erectospinae group of muscles. Here the erectospinae group of muscles, this was your longissimus, and just medial to that is your below and medial to that is your multifidus, and this was your iliocostalis. So what is the difference between the thoracic area? Thoracic area, another muscle is coming above the multifidus muscle is your the spinalis muscle. So now here, if I'm removing this, so these are erectospinae group of muscles. So then these are all posterior to the transverse process. Remember it. Now, lateral to the transverse process, this muscle is what muscle? This muscle is your erectospinae muscles. And this glistening structure is your middle layer of the thoracolumbar fossa. So this is your middle layer of thoracolumbar fossa. If I'm removing that, then this muscle is your quadratus. And quadratus, if you are removing, this is anterior layer of the thoracolumbar fossa. This muscle is your what muscle? Anterior to the, this is a psoas. And in between the two transverse processes, this muscle is your intertransverse lateralis, and this muscle is your intertransverse medialis. So transverse process and intertransverse muscle is bridging, making a layer. Anterior to that is your psoas. Posterior to that is your erectospinae group of muscles. Lateral to that is your quadratus. Okay, very simple to remember in the lumbar area. Transverse process is making the divisions. Transverse process within the two transverse processes is your intertransverse muscle and ligament. Anterior to that transverse process is your psoas. Posterior to that transverse process is your erector spinae. Lateral to that transverse process is your quadratus group of muscles. And in the erector spinae group, we are having the three muscles. Most medially and deeper is your multifidus. After that, longissimus. After that, iliocostalis. And in the thoracic area, another muscle is your spinalis muscle. Okay? Is it clear? And now here, so here, few things to remember, because today I'll be showing the SI joint as well. So see, this is the SI joint. SI joint has the two layers, two part. One part is your this part, upper part, and the posterior part is your fibrous part, and lower part and the inferior part is your anterior and inferior part is your synovial. So sometimes we give into the synovial part, particularly if you're inflammatory arthritis, or sometimes we give it in the degenerative conditions, we give it injections here. So here you see, this is S1 foramen, S2 foramen, S3 foramen. This is a posterior superior spine. Posterior superior spine corresponds to the S2 foramen. So when we will be holding the probe here, let me remove the connective tissues also, ligaments also. So if you are holding the probe here, what you can see, this is your spinous process of the sacrum, which has another name, which is called medial sacral crest. After that, this is a lamina, then the foramen, and then there is another elevation. This is known as the lateral sacral crest. And then comes your sacroiliac joint, and then comes the iliac bone, posterosuperior spine. So posterosuperior spine, then there is a SI joint, then there is a lateral sacral crest, then lamina or foramen, and then most medially is your, what is this called?
Sir, it is zoomed out a lot, sir. You're not able to see the medial part.
What?
It is zoomed out a lot, sir. The picture.
Okay, can you see now? So I asked, what is the structure? This is medial sacral crest. Sacral spinous process or medial sacral crest, then the lamina, foramen, lateral sacral crest, then the, okay. And now for the caudal epidural, we have to find out there is a gap in the medial sacral crest. Coming below medial sacral crest, there is a gap which is known as the sacral hiatus. So this is one cornu, there is another cornu, and this is covered by a membrane, sacrococcygeal membrane. So you need to find out this sacrococcygeal membrane. You have to pierce it in the long axis to go for the caudal epidural. Okay, so up to this, if you have any question, if you want to see anything in this anatomy, I can show you again, and then I'll be going for the, okay, thoracic muscles a little bit complicated. Shall I repeat once again? Yes?
Yes.
Okay. So this was trapezius, transverse layers part of the trapezius. Above is your superior or the descending part. This is your inferior or the ascending part of the trapezius. So let us remove the trapezius. And then let me reduce the zoom out. So here, this was the medial border of the scapula. This is your spine of the scapula, which is becoming acromion. So this muscle is your supraspine. Now at the level of the spine of the scapula, below the trapezius, we are having this muscle is your rhomboideus
Minor.
minor. Very good. Above that spine of the scapula, below the trapezius, the muscle is your
Levator.
and below the spine of the scapula, below the trapezius is your
Rhomboid major.
So in this layer, we'll be getting the spinal accessory now, right? And then if we are removing this layer of muscles, second layer muscles, then we'll be getting which muscle? This is your
Posterior.
posterior superior muscle. So between the rhomboideus and the second layer muscle and third layer muscles, we'll be getting the dorsal scapula now. Okay, I forgot to mention another important thing, which is called winging of the scapula. Okay, so many times you'll be getting the upper thoracic pain, you'll be getting the winging of the scapula, drooping of the scapula or shoulder. These are the two things very, very important. If there is a drooping, you have to think that this is a spinal accessory nerve entrapment because of the trapezius myofascial pain. And if there is a winging of the scapula means, suppose this is the blade of the scapula. If it goes laterally, then it called lateral winging, right? If it is going medially, then it is called medial winging of the scapula. So now you need to remember which pulls scapula laterally and which pulls scapula medially. So which pulls scapula laterally? It is serratus anterior muscles. Okay, if I am removing the latissimus muscle, so this is the serratus anterior muscles. Serratus anterior muscle is from, what is the original insertion? From ribs, from 1st to 9th ribs, and they are getting attached in the medial border of the scapula here. And they pulls the scapula laterally. So, and this muscle, serratus anterior muscle, is supplied by long thoracic nerve. So, if there is a long thoracic nerve entrapment, then the scapula will be moved laterally or medially?
Laterally.
Laterally.
It pulls laterally. If it is a pulse, medially.
Medial winging.
There is a long thoracic nerve palsy, then serratus anterior muscle will be weak, so it will not be able to pull it laterally. So the medial winging of the scapula. Then we need to know who pulls scapula medially. So
Rhomboid.
common sense. Rhomboid. So rhomboid is supplied by dorsal scapula. Dorsal scapula supplies two nerves, two muscles. One is your rhomboid, rhomboidus major, minor, and levator scapula. All of them pulls medially. So if there is a dorsal scapular nerve palsy, then what will happen?
Lateral winging.
Lateral winging. And it is very common, upper thoracic areas. If you see that the scapula is moved laterally, that means it is lateral winging. And to find out the lateral, so what you have to do? Here you have to go for the plane between the rhomboidus and your what? Serratus posterior superior. That means between the second layer and third layer. And you can hydrodissect with the 5% dextrose will be having the very good effect. And if you are having the long thoracic nerve palsy, then what you have to do? Many of you are anesthesiologists, you must be knowing this. Serratus anterior plane block. So the serratus anterior and plane block for 5% dextrose there, if you are giving, then the long thoracic nerve can be hydrodissected. And if there is a medial winging, then our target is your long thoracic nerve. That means serratus anterior plane block to be done. And when it is the lateral winging, then you have to go where? Between the rhomboidus and serratus posterior. Okay? Clear? Above the serratus posterior. If there is a, just you can very simply remember this thing. That if there is a medial winging, then you have to inject anterior or superior to the serratus anterior muscles, where the long thoracic muscle nerve is coming. And if there is a lateral winging, then you have to inject above the serratus posterior superior, because between the serratus posterior superior and the rhomboidus is your the dorsal scapular nerve is running. Okay, so now if I am removing this, we are having the posterior layer of the thoracolumbar fossa. So posterior layer of the thoracolumbar fossa, if you are removing, then comes the erector spinae group of muscles. Erector spinae group of muscles, the muscle which lies over the transverse process is your longissimus. Medial to that is the spinalis, and below spinalis is multifidus. Lateral to that is your iliocostalis. These are erector spinae group of muscles. Okay, now let us go for the demonstration.
Yeah.
You want to say anything? Yes, tell. Anybody is telling anything? Okay, now let us go for the demonstration. My volunteer have slept. Okay, so now he is awake. So, Siris, can you see my volunteer?
Yes, sir. Yes, sir.
My volunteer is ready.
So the up. Sir, one camera is not.
One camera is not focused. I'm focusing. Please give me some time. So, ওখান থেকে যদি সামনে দেখা যাচ্ছে, আমি পিঠ দেখা। ওই পিছনে লিখে দাও, এখানে লিখে দাও, এখানে লিখে দাও। Okay, one close-up camera, another.
Yes, sir.
You can see now nicely. So now what I'm doing, so what I'm doing, I'm calculating the spine of the scapula. You can see spine of the scapula. So now I'm holding the probe here, medial border of the spine of the scapula. Okay, so you see how I'm holding the probe, and now I'm freezing it. Let me draw now. So what is this? This is the medial border of the scapula. I was just, here is the spine of the scapula. I'm just above the spine of the scapula. So this is your stroke or blade in the supraspinatus fossa. So what muscle will be this one?
Supraspinatus.
Supraspinatus, very good. And then you can see there is a muscle there. This muscle is a little bit thicker and then comes like this. So what is this muscle?
Trapezius.
Trapezius, very good. And then I was above the spine of the scapula. So what will be the second layer muscle? Below the trapezius, above the spine of the scapula.
Rhomboidus minor.
Levator scapulae.
At the left spine of the scapula will be rhomboidus minor. And then what will be this muscle? This is your serratus posterior superior. And then what will be this muscle? This is the lateral most muscle of the retrospine. That is your ilioposteris. So you see, you can see this all the layers of muscles. This was your trapezius. I'm just clearing the drawing again. So this was your trapezius. This was your levator scapulae. This was your serratus posterior superior, and this was your ilioposteris. Is it clear now? So if you will be finding something here in this layer, that will be your and you'll be finding something here, that will be your dorsal scapula. Okay, now let me unreach and show you. So I'm holding the probe here. So spine of the scapula, I'm going above. So I can see this layer of the muscle, most top muscle. So left hand side, this is your medial edge of the scapula. This is the supraspinatus fossa. So this is your trapezius. So now below the trapezius, we try to find it out. Something, let me reduce the depth, then you'll be able to understand it better. So some black area pulsating there. Can you appreciate that? So that is the vessel and the spinous renal. Can everybody appreciate that? Say yes or no.
Yes, sir.
Okay. So then levator scapulae muscle, and then try to find out something here. That is your dorsal scapular nerve accompanying blood vessel. Below that, which muscle? Serratus posterior superior, and below that is your the erector spinae muscles, and below that this is your glycerin pleura. So when the most glistening, even it is glistening more than rib, is your pleura. If I'm coming here, then is your above and below, then it is rib. But here this is your pleura, and it is also moving with the respiration itself. So this is your dorsal scapular nerve block and the spinal axillary nerve block. I hope everybody has appreciated. So what do you have to understand? You just feel the spine of the scapula, go above the spine of the scapula. So this is your supraspinatus muscle. This is your trapezius muscle. Below the trapezius muscle, here is your spinal axillary nerve. And if you're looking a little bit down, here is your dorsal scapular nerve. Everybody understood it? This is very common. Nowadays, we don't give the trigger point injection. We just give the dextrose injection in this muscle plane, here and here. That is much more effective. Okay, now let me go to the middle part of this. So let me put some more gel there. A little bit. Series. Muted.
Yes, sir.
Okay. Okay. So here in the middle of my screen, what you can see there is the spine of the scapula. Can everybody appreciate that? Yes.
Yes, sir.
Sorry, it's not spine of the scapula. Spinous fossa. Sorry, I extended sorry. And then I'm holding the probe here. So what muscle is this? What is this muscle? This is your multifidus muscle. And that above that, this muscle is your spinalis muscle. And then here there are two layers of muscles here. One is trapezius, and below the trapezius is your rhomboidus muscle. And if you are going laterally, this muscle is your longissimus muscle. This is the transverse process. And what I was telling, you see here, this part, this is the lamina, this is the very deep. This is superficial spinous process, this is transverse process, this is again superficial. And above the transverse process is your longissimus muscle. And then if I am going more lateral, this is your pleura, as I was telling, very hyperechoic is your pleura, not rib. If I am going little above, now pleura comes. If I am coming down, then rib comes. This is a rib. And this is your costotransverse joint. If I am coming down, then it is your glistening and moving, that is your pleura. If I am going up, and in between your external and internal intercostal muscle. And if I am going here, we cannot see the intercostal muscles, but you can see the transverse process, and this is your costotransverse ligament, costotransverse joint, and this is your lateral costotransverse ligament. I told you lateral and the superior costotransverse ligament. This is the lateral costotransverse ligament, which is between the rib and the transverse process. So in this position, if you wish to give the the erector spinae block, your needle can come like this and give injection, or you can give it the long axis also. Long axis I'll be showing. So now in these positions, so this was the muscles as I was telling, below the iliacostalis, The lateral to the iliocostalis is your longissimus in the iliocostalis. So this is your iliocostalis, lateral most. And then if you are going more laterally, then you can remember this was your latissimus, these are the trapezius, then is your here and below. So here it is the rhomboidus, and then below the rhomboidus is serratus, and after that is your this was your ribs. Here these muscles are the external and internal intercostal muscle. If I'm here, then below the rhomboidus we are having the rib. Okay, so this was your transverse view. So here also another important thing I forgot to mention is if you wish to do the paravertebral block. So paravertebral block can be done here. So here you can see this is your pleura, this is your transverse process. So this is your membrane. And you can pierce it and you can go into this. So this is your long axis, this hot axis. If I'm going to the long axis view, my aspect marker is on the cranial side. And this is your spinous process. And now I'm going laterally. So what I can see here, so as I told you, this was your lamina. This is your interlaminar space. And just above the laminar space, this is your multifidus muscle. Above that is your spinalis muscle. Above that is your two muscle. One is your trapezius, very thin layer, and below the trapezius we are having the rhomboidus muscle. Rhomboidus muscle also gets attached there in the spinous process. Now at this point, if I am going laterally, so here you see gap between these two is much big. This is interlaminar space. Now if I am coming laterally, see what is happening. See what is happening. Now suddenly it starts elevation, and you see this is a big gap, soft tissue. So that means we have come towards the edge of the lamina. And if I am going still more laterally, then this is your transverse process. Transverse process is little flat, not like the rib. So if you wish to do another option to do the paravertebral block is, you can understand this is the costotransverse ligament. This is the transverse process. This is the rib is below here. So this ligament obliquely is a costotransverse ligament. So what you can do is in your out of plane, you can come here and you can inject here above this glistening structure. So this space you can give for the paravertebral injection as well. So again, it become, so this was your midline spinous process, you can see. This was the spinous process. And then I'm coming here. So this is the bigger gap, so interlaminar space. Now come more lateral, and now see the space between these two spinous processes has increased a bit. So now you go little more medial. At this position, you can go for the thoracic thoracic joint injection. If I'm going more lateral, here is the gap is increasing at this point. At this point, you can go for the injection. If you are going more lateral, then transverse. Now at this point, if this was flattened, I'm going more laterally. See what is happening to the transverse process. Transverse process is very bright listening. Okay, this is another way to give the erectospinal block. Come here, long axis. See how I'm holding the probe. In this way also, either cranial to caudal or caudal to cranial, you can come and inject here. At this position, if I'm going more lateral, see transverse process is vanishing. Now there is no transverse process. Now rib is started appearing. Transverse process, remember, is more superficial. Transverse process is more superficial and more flat than rib. Rib, you see, more rounded. See, more rounded. And you'll be able to see the pleura, very bright, glistening pleura. So here it was transverse process. Here it is pleura. Here it is transverse process. Here it is pleura. So if you used to do the intercostal nerve block, so you can see something pulsating here. So your needle should be coming here. Always intercostal nerve is better done with ultrasound because the chances of the pleural puncture, pneumothorax is much less when you are having the ultrasound as a guidance. Okay, so if you wish to ask anything, you can see thoracic area, now going to lumbar area. Wish to see
Sir, can
anything?
you show again the thoracic facet, please, sir? Because
Okay.
there is the very small gap so far.
We start from here. This is your spinous process, right? Appreciate spinous process. Now I'm sliding it just, then slightly the gap is increasing, and this is your lamina. So here is the gap is bigger, lamina. And now I'm going lateral. Now it is facet joint. So this is your facet joint. And still laterally, now the gap between the lamina is increasing again. That means we are towards the lateral edge of the spine, and then the elevated part is your transverse process. Okay, is it clear? Look at the anatomy here again. I'm just
Okay,
stopping
sir.
sharing. I'm stopping sharing here, and you see here this part, then we'll be able to appreciate it better. Okay, so let me remove all the muscle here there. Okay, see here, initially my probe was at this position, spinous process, then the lamina, and then more laterally facet joint, just a little bit. And then suddenly there is a up and transverse process is here. So when I am at this age, the gap between these two hyperechoic line bone will be suddenly increasing. That is the lateral edge of the spine at this point. So that is not the facet joint area. You have to go a little more medially to have come here in this point. And then suddenly there will be slope for the transverse process. Is it clear now?
Yes, sir.
Anybody wish to see anything in this thoracic area?
Sir, one.
Anybody wish to see anything?
Sir,
Yes. Paravertebral block.
Yes, sir. Paravertebral, longitudinal and short.
So paravertebral block can be done by two ways. One is if we are okay, my aspect marker is towards. Okay, first let me see the easier one. So what I am doing here, I was here. So you can understand what are the layers. So this is your spinous process, this was your laminar transverse process. Now if I am going laterally, so what is this?
Pleurus.
Very good. And if I'm stepping above, this is your reading. This is your transverse process. So at this position, your needle should come here and inject here. Just below the just lateral to the acoustic shadow of the transverse process and above the pleura. So this is in-plane technique. This is safer. And another is your out-of-plane technique. So now aspect marker is above. And what I am trying to do, I am trying to do between the holding the probe between the two transverse processes. So here, facet joint area, now going laterally. Now the transverse process is projecting up. So at this position, this was your rib, this was your transverse process. So there is a ligament there, superior costotransverse ligament. And you see the pleura is moving here, and your needle should come here in this direction. Okay, this can be done both out of plane or in plane, both. You have to puncture this superior costotransverse ligament. Superior costotransverse ligament is now very nicely seen. So from here till here, these are the superior costotransverse ligament. You have to come here and is it clear?
Yes, sir.
And Spinal block is very easy. In this position, same position, electrospinal block. You come here and what is this muscle? I told you, transverse process, above the transverse process. Longissimus muscle. All are electrospiny, but again, there are 4 layers, no?
Yes.
On the transverse process, this is your longissimus. So this muscle, what you can see here is longissimus. So you come here or come here and inject over here. And you can inject 2-3 layers also, not just here. Here also you can inject 2-3 areas. And this is also very not just anesthetic block. This can also be very nicely done. For I have done in many patients where the patient is having the myofascial pain in a wider area in the back. You can give the electrospinal block there, and it gives very good result. Excellent results. Okay.
Sir,
Anything
how,
else?
sir, how to this suprascapular nerve?
Suprascapular nerve block. Suprascapular nerve block. Have I not described it in the shoulder? Huh?
You described.
Okay, just stand.
Okay.
You can do it as the suprascapular notch. But nowadays, again, let me show you the anatomy first. Otherwise, you will not be able to appreciate it nicely. So let me show you the anatomy. So this is your suprascapular notch. This is the spine of the scapula. What is there? This muscle is supraspinatus muscle. So here we'll be seeing the 2 layers of the muscle. One trapezius, below the supraspinatus muscle. And the nerve comes here and comes like this. Let me put the nerve. See what is the course of the nerve. Just a minute. You see, this is the supraspinatus nerve. Is this one. And it gives, branch to the, this is your muscular branch to the supraspinatus. And then it comes here. This is your spinoglenoid notch. And it gives supply to the infraspinatus and also supplies to the shoulder joint. So classically, suprascapular nerve block can be done here. Or nowadays, we don't do that because here, if you are blocking, you are basically paralyzing the supraspinatus, infraspinatus muscle. So nowadays, to avoid weakness, nowadays we block it here so that the shoulder joint will be innervated, but the supraspinatus and the infraspinatus will not be affected. So I'm showing you the probe here. You can do it here, but this is obsolete. Today morning only I was telling that the suprascapular nerve block here is written in the history book, not the, in the current pain management book. So current pain management, you have to put your needle here over the glenoid. I'm showing you both quickly. Though this is not today's topic, but today is the last day. I'm just trying to clear that out. So my aspect marker is towards the lateral side. And I'm palpating the spine of the scapula. I'm putting the probe here. When I'm putting the probe here, short muscles, what can you show? I just little above. I was here only.
Screen not shared, sir.
Just remember. Okay, sorry. I have not shared the. Sorry. Let me share the. Okay. So just now I was showing this picture. You just remember these things. Can you remember this picture? Just little ahead, I was talking about this. So, what was this? Medially, this was supraspinatus.
Spine.
Not spine of the scapula. Spine of the scapula, you cannot see the muscle. This is the spine of the scapula. See, you will not be able to see the muscle. But here it is your supraspinatus fossa. So now this is your supraspinatus, the blade above the supraspinatus. This muscle is your. What is this muscle? This one?
Trapezius.
Trapezius. Very good. And below that, what is this muscle?
Supraspinatus.
Supraspinatus.
Now it is coming more medially, more laterally. So this is a break here. Some pulsation here, and you can do the block here. At this suprascapular notch. Can you see the pulsation here? Black dot and pulsation. and there is a ligament there. Sometimes nerve, most of the times nerve is below that ligament, or sometimes the above the ligament also. So that is the classically suprascapular nerve block can be done there, but as I told you, nowadays we don't prefer it. Nowadays we prefer to block the we prefer to block here. So here, if I am holding the probe, you see this was your head of the humerus. This is your glenoid, and this was your labrum, and this is your spinal glenoid notch. So if I am blocking you can see the pulsation there. Very carefully, I am fixing it, and you just the nerve is also very nicely seen there. Okay, so that is the supraspinatus, suprascapular nerve. This hyperechoic honeycomb structure, very nicely seen. You'll not be able to see so nice nerve, suprascapular nerve there. So how do you have to do? You have to block here. Then you will be able to give the pain relief from the shoulder without paralysis of the supra or infraspinatus. Clear?
Yes, sir. Yes, sir.
Yes or no?
Yes, sir.
If not, go
Yes,
again.
sir.
Okay, thank yes, tell. Tell.
Sir, can I ask any more if you are not feeling disturbed? Pudendal nerve, if you
Pudendal nerve
show
also.
again, please.
Unless we are having a good volunteer, I'll not be able to show the pudendal nerve. Pudendal nerve I show you other
Okay,
day.
sir.
You have to look for
Okay,
the
sir.
scapula because I cannot show this volunteer. Okay, let us concentrate on
Okay, sure,
this
sir.
area. Okay, anything in the thoracic area? Anybody? Okay, now I'll be showing you going to the lumbar area. The lumbar area again will be normally starting with a short axis view. And there, first, let me change the probe. Let me reduce the depth a little bit. So my aspect marker is towards the cranial side. So what you can see here, this is your what? Somebody unmuted.
Spinous process.
Not spinous process. If I am holding
Transverse process.
transverse. So this is one transverse process. This is one transverse process. This is also called transverse process view. Okay. So here, what is this muscle? Erector spinae muscle. And you can see the two layers there. In between these two layers, this is your intertransverse tissue complex or intertransverse muscle and ligament. And below that, this is a muscle. This is your psoas muscle. So above is your erector spinae. In between is your intertransverse. And below the intertransverse complex is your psoas muscle. Is it clear to everybody?
Yes.
Transverse process view. I was here. Transverse process view. And I was seeing the two hyperechoic line intertransverse tissue complex. Above that is your erector spinae, and below is your
Psoas.
psoas. Now, if I am going from here laterally, see what is happening. Transverse process is vanishing. Transverse process is vanished. And now the two hyperechoic lines comes. So these are the middle and the anterior layer of the thoracolumbar fossa. You can see the peritoneum is moving here. Here it is not moving. This is your psoas. This is your QL. This is your electrospiny. Lateral most electrospiny is your
Iliocostalis.
iliocostalis. So can you appreciate the three layers of muscle, three distinct layers of muscles here? Everybody?
Yes.
In between is your quadratus, above electrospiny, below psoas, and after that is your the peritoneum moving. And you see, if I'm going above, the psoas is thinning out. If I'm going below, the psoas is little bulkier. See, psoas here is bulkier. And if I'm going above, psoas is less. Here, psoas is bulkier. So here also, you can see
Thoracolumbar fascia.
thoracolumbar fascia. This is the anterior layer thoracolumbar fascia. Thoracolumbar fascia, anterior and the middle layer encloses the quadratus lumborum muscle. Okay, and posterior layer is posterior to the erectospinal group of muscle, and superior to that or posterior to that is your latissimus dorsi muscle. So, what are the three layers? The most posterior layer is between the latissimus dorsi and your erectospiny. Then the middle layer is between the erectospiny and the
Psoas, sir.
middle layer between electrospiny and
Psoas.
quadratus, and the anterior layering between the quadratus and the psoas. Okay, so this is the anterior layer between the psoas and quadratus. This is middle layer between the quadratus and the erectospiny. This is the posterior layer between the erectospiny and the latissimus. Latissimus also is very thin layer of muscles. This is your posterior. Right. So if you wish to do the QL block, your needle can be inject here or you can inject here between the the erectospiny and the quadratus or quadratus and the psoas. So now if I'm going more medially, what is happening? If I'm going more medially, then this is suddenly, you see here is a transverse process. Here is a transverse process. Suddenly, you see this is transverse process. Suddenly some bone is appearing. So what is that bone? Here it is transverse process. Here some bone. This is your mammillary process. Transverse process, mammillary process. And if I'm going little more medially, this is your articular process view. This is your mammillary process view. This is your articular process view. And if I'm now tilting it more medially, this is your
Lamina.
laminar view. And we can see the posterior complex and the anterior complex. Okay, here it is very nicely seen. Let me change it. So here there are two lines, and in between two lines is your posterior apical space, and there is a gap, and there is your anterior. So this is the posterior complex. This is the anterior complex. And posterior complex, what are the layers? The dura and the ligamentum fibrum. And the anterior complex, what are there? The dura, anterior dura, and the posterior longitudinal ligament. Okay, I'm showing you again. See here. I'm going more medially and I'm tilting the probe. When I'm tilting the probe, then this is also known as horse head view, it looks like a horse head. So this was your ligamentum fibrum. This black area is the posterior apical space, and here is your anterior complex. Right? So this was your in the long axis. I'm coming a little more down. Let me show the SI joint. Okay, SI joint I'll be showing you later on. This is the short axis. Short axis, I'll be taking the straight.
Water,
the
Kak. Can I
linear.
water for me, sayang?
No, the normal
Okay.
water. Mm.
Please remain muted when you are not talking, please. Okay. So here, sometimes I am. Let me increase the gain a little bit. So when I am over the transverse process, the spinous process, we cannot see anything beyond. So the middle is my spinous process, and I cannot see anything below. But if I'm coming in between the two spinous process, then what is happening? I can see everything below. And if I'm clearing here, what can I see here? So this is your lamina. This is your lamina. This is your transverse process. This is also called the bat view. Looks like a bat. This is your posterior complex. This is your anterior complex. And this muscle is your multifidus muscle. This ligament is your interspinous ligament. Okay. So this is known as bat's view. It's like you see, like the two wing of the bat. The two wing of the bat. So it's called bat's view. Or it is in between the two spinous processes. You can see the lamina, and we can see the anterior complex, we can see the posterior complex. Okay, so now again, so see, this was your bat's view. No, I'm seeing the anterior complex, posterior complex, and if I'm going laterally, see, I'm treating it here. So what can I see here? So here, this was the lamina. This was your transverse process. This was your multifidus muscle. This was your longissimus, and this is the iliac prostalis. All together is your spinal cord muscles from here. And then I cannot see here anything. So this was your acoustic shadow. So if you wish to do the medial branch block, your needle should come like this, and you inject here, and you can find out some pulsations there. That is the blood vessel accompanying the, and this was your mammillary accessory ligament. Okay, so I'm showing again. So just try to focus it here. In these areas, find out some pulsations. This is the transverse process. If I'm skipping above, transverse process is vanished. Then this is your psoas muscle. But when I'm over the transverse process, this is I'm over the transverse process. So to do the medial branch block, I need to find out the transverse process. Here, no transverse process. Here, transverse process. So I need to find out the transverse process and see some pulses there. Just most medial most area. Okay, so that is where the medial branch block should be done. And if I am sliding little like this, so this is the area where I can do the intra-articular injection of this area. I can go for the intra-articular injection of the facet joint. So here, when I'm seeing the transverse process very nicely, then here I have to do the medial branch block here. And when I'm sliding the probe little above and below, to see the break in the lateral part of the. So here is your intra-articular facet joint. This break. This break. Okay, so this is your intra-articular joint. So now the joint division is very nicely seen. This is your intra-articular joint. You'll not be able to see that much of big joint in every patient because the patient is lean and thin, flexed maximally, so the joint has opened up nicely. And for the medial branch, you need to see the transverse process. Okay, and if I'm coming more laterally, this is your QL. These are two layers of the thoracolumbar fascia. This is your QL muscle. These are all in the long ilioposternal longissimus multifidus muscle, and here is your psoas muscle. Okay, is it clear to everybody? Wish to see anything again? So just quick recapitulation. I was here. I can see this is bat's view, anterior complex, posterior complex, lamina. Then I'm going laterally. I can see the transverse process for the medial branch block here. If I'm toggling above and below, I can see some break there. That is your facet joint injection, interarticular facet joint injection. If I'm still going laterally, I can see this is your QL muscle and between the two layers of the thoracolumbar fascia. And above that is your electrospinal loop of muscles. Is it clear to everybody?
Yes, sir.
Yes, sir.
Now, again, I'll be taking the curvilinear probe. Now I'll be going, seeing the spine from the lateral view. I'll be holding the probe here. I have to focus. Change now. So now you see how I'm holding the probe. I'm holding the probe like this. Say I'm holding the probe like this. Okay, can you see how I'm holding the probe? My aspect marker is anteriorly. Anterior side is your, that means left hand side of my screen is your. Yes. Okay, now you see what you can see here. So here, this in bowel preparation is not nice. To see it from the lateral side and anterior side, bowel preparation must be very nice, otherwise it's difficult to appreciate. So anyway, so what is this? This projection, let me draw it. This projection is your transverse process. And this is your vertical body. This is your psoas muscle. This is your QL muscle. And this is your electrospinal muscle. Can everybody appreciate it? Vertical body, transverse process, QL, psoas, electrospinal. Everybody can appreciate it or not? Say yes.
Yes, sir.
Let me reduce the depth a little bit. Okay, now if I'm holding the probe little more like this, and I'm tilting the probe, you see, transverse process is vanished. When the transverse process is vanished, this is the area of the neural foramen. You see, transverse process is seen. This projection is transverse process. Now, tilting the probe, I'm in between the two transverse processes. And here you can, this is the foramen. And you can see the nerve, this hyperechoic and hyperechoic structure is your nerve, exiting nerve root. See, that is the exiting nerve root. I'm tilting the probe, and it is coming within the layer of the psoas. Ventral rami comes like this into the psoas. And dorsal rami goes posterior over the transverse process. So if you wish to do the few blocks, lumbar-sympathetic block, your needle should come like this. If you wish to do the transforaminal injection, your needle should be coming like this. If you wish to do the QL block, your needle should be coming like this, coming here. This is QL. Okay, if you wish to do the electrospinal block, then your needle should be coming over the transverse process here. So in this view, lot of procedures can be done. Okay, so over the, this is the transverse process. Very nicely seen. Now transverse process is vanished, and now the foramen is seen. Nerve root is seen. Hyperechoic, this structure. This is your nerve root. Now the transverse process. Now nerve root is not seen. Now nerve root is seen. Now transverse process. And posterior to that, this muscle is the electrospinal. Clear? This view? Okay, okay, now I'll be showing two more procedure. One is your camera focus. I want to get clear. I want to get clear. It depends on all of them. Okay, so what I was telling, if I'm increasing the gain little bit, So this was, I was holding the, what I can see it here. So I calculated that the posterosuperior spine. I'm at the level of the posterosuperior spine. So this is your part. This was your medial sacral crest. Now, if I'm going down, now see medial sacral crest is vanished. And now the two cornues are appearing. So these are the two cornues, one cornu, another cornu. And this is the sacral bone. And in between, we are having the sacrocoxygeal ligament. Let me redo the tape so that you will get this in it. So I was here, and now I'm seeing the two cornu. And at this position, I'll be rotating the probe, craniocaudal. So this side is your cranial side, left hand side, right hand side. So this was your medial sacral crest. This was your medial sacral crest. Medial sacral crest, this is your sacral bone, and this is your the sacrocoxygeal membrane. See it again. So this was your medial sacral crest. So this is, if you wish to go for the caudal epidural, the needle should be coming like this and injecting here. Okay, is it clear? So if I'm going more laterally, you'll be able to see one cornu, and here also another cornu on this long axis. So here, what we have to do, we have to identify these two structures. Let me see a little bit still better. Okay, so this was your sacrum, and this was your, this is your bone. Bone comes up to here because we can't see anything there. So your needle should be coming like this. So this is your caudal effort. And for the SI joint, again calculate the posterosuperior spine. You hold the probe there. So at these positions, what can I see? On the left hand side, this is your posterosuperior spine. This is your medial sacral crest. This is the lamina. This is your SI joint. So if I'm tilting it little down, so this now here is focusing. So here what you can see, this was your ilium, this was your lateral sacral crest, this was your medial sacral crest, and see ultrasound is going down. So this is your S2 foramen. So again, I was here initially, posterosuperior spine. This is a break SI joint. This is your fibrous part of the SI joint. This is your spinous process or medial sacral crest. Now, if I'm coming down, see what is happening. This iliac crest height is reduced. So, if you wish to go for the synovial part of the injection, then you should not be injecting here. In this, if you are coming here and injecting here, that is your fibrous part of the injection. And if I'm coming down, see, this is reduced in height. And now the S2 foramen is appearing. Here S2 foramen is not there. But now here you see ultrasound is going down. S2 foramen is appearing. So now you can see there is two bony break. One bony break is here, ultrasound wave is going down. So this is the synovial part of the SI joint, you can come here. And another is your S2 foramen that is going down here. So normally we are injecting here where the iliac crest is reduced in height. See here, and S2 foramen is seen. Here, if you are injecting into the fibrous part of the joint. So this is also area where it can be injected, but that is your fibrous part of the joint. If I'm coming down here, iliac crest is very much almost at the level of the sacrum. This is your sacrum, lateral sacral crest, iliac bone. This is your S2 foramen. This is your medial sacral crest. So SI joint can be done here as well. This is the lower part of the SI joint.
Sir, S2 foramen.
S2 foramen, you see, this is S2 foramen. This is S2 foramen. This is SI joint. This is lateral sacral crest. This is medial sacral crest. This is the ilium. This is the S2 foramen.
Okay.
S2 foramen Indication for the S2 foramen injection is very rare. S1 foramen injection is more injected, and that is more commonly better done with the CM, not by the ultrasound. But still, if you wish to be asking me to show the S1 foramen, easy. At this level to the S2 foramen. Now go above. You see the lamina is coming. Lamina. Then again, when the ultrasound beam will be going down, so this is your S1 foramen. This foramen is your S1 foramen. Here. But again, it is S1 root block is not done like this. S1 foramen is done under the CM guidance. Okay. Practice, see the recordings, practice, then you'll be able to master it. If you have any questions, if you have any doubt, I can show it again. Otherwise, some long list of class to be taken by series now.
One last time, transforaminal can you?
Transforaminal epidural.
Yes, sir.
Okay. Transforaminal epidural is not done, but we have a very nice technique by ourselves. You can see that in the YouTube also, it is there. But I will not be recommending to do the transforaminal epidural, but still, it is possible. You see, here, this was your transverse process. Can you appreciate? Let me increase the depth a little bit. So this was your transverse process. Okay, so this was your transverse process. Okay, this is your transverse process. Transverse process. Now at this point, I am sliding the probe medially. And then what will happen? Some bone will come. So this bone is your what? Tell what is this view? So this was your transverse process view. This was your transverse process. And now if I am moving it medially, some bone is coming. This bone is your mammillary process.
Mammillary process.
This is mammillary process, this is mammillary process. And in between the two mammillary processes, the foraminal area, but that can be better seen at this point. What I am doing, that this left hand side is your cranial side. I am tilting the cranial side back towards the transverse process. So now at this point, this is your transverse process which is deeper. This is your mammillary process which is superficial. And here is your nerve. So transforaminal injection can be done by this way. This is our own technique. So this is one option. Here, classically, what is done here, in the book, it is described in between the two mammillary processes, you can go it by out of plane technique. But out of plane technique is always dangerous. You know, here, this is your nerve. Out of plane technique is dangerous. In plane technique, what we do, this part, I'm taking it back. So now this is your transverse process, this is your mammillary process, and you can see the pulsating blood vessels in the nerve here. So your needle can come like this, can be instantly in the lower part of the foramen. You can go injection like this. So this is one of the safer technique, and you can do this transfer. But again, transforaminal, and you can see the pulsating vessel in the foramen. Transforaminal epidural is always advised to do under the CM guidance, that is much safe. Okay.
Thank you, sir.
Okay, now series. I hope no more request to show anything. If anybody wish to me to show anything more, I can show. Otherwise, you can see the recording again and again. Practice it. Unless you are practicing ultrasound, you will not be able to see the understand the ultrasound. So you need two things: anatomy. You need to understand anatomy very nicely, and you need to scan it again and again. As much scan you'll be doing, you'll be able to understand the ultrasound much better. There is no alternative for the scanning. Okay, series. You
Yes,
can
sir.
go. And again, just for the announcement that, okay, from tomorrow, we'll be having tomorrow evening, the exam link will be open and you can take the exam over the next 2 weeks' time. All the videos will be available till you are completing the exam. So there will be 3 chances will be given. If you are securing 50% marks, then you cannot go ahead with the second attempt. So second attempt is only those who will not be able to secure the 50% marks. If you are securing 50% marks in the second attempt, then you will not be going to go for the third attempt. And as soon as you are completing securing more than 50% marks, your certificate will be automatically generated in the system and you can download your certificate. But I have seen in the basic course, many of you have not uploaded your photographs. If you wish that your photograph contains your certificate contains your photograph, then you must be uploading your photograph there. And then you complete the exam. And after completing the exam, you have to give the feedback also. That is mandatory before leaving out and downloading the certificate. Okay, thank you very much. From tomorrow, the exam link will be open. And till you are completing the exam for the next 2 weeks, you can see all the recorded videos again and again.
Okay, sir. Okay. Is my slide visible, sir?
Yes, your slides are visible.
Okay. So good evening, everybody. We are almost at the end of our class. Today, I'll be talking about some thoracic and lumbar pathologies and as well as a few interventions that is commonly done in day-to-day practice. Let's start. So today we'll be covering these few topics. So we are basically covering spinal accessory nerve and dorsoscapular nerve entrapment. We usually give SATS block in this. Actually, this SATS block is commonly done in the pain clinic, which I think in next musculoskeletal ultrasound pain medicine book, it will be published. This is the special technique which was done by Dr. Gautam Das, and I'll be discussing that technique. After that, we'll be talking something about intercostal nerve block, followed by erectrospinal plane block, and followed by some lumbar ultrasound pictures, as well as lumbar medial branch block. So these things will be covered in today's class. So starting with spinal accessory nerve and dorsoscapular nerve block. Neck pain and as well as upper back pain is a common complaint in pain clinic, as because we are using a lot of time, we are using like smartphones and mobile, and most of the time our neck is flexed. So this has led to a common problem known as tech neck problem. And because of tech neck problem, various myofascial pain, especially involving trapezius, levator scapulae, and rhomboid muscles, as well as cervicogenic facet problem are commonly seen nowadays in day-to-day pain clinic. And in these conditions, we should also not forget about the spinal accessories as well as dorsoscapular nerve, which can be entrapped when the muscles, like especially the scalene muscles as well as rhomboid muscle, gets hypertrophy. In these conditions, spinal accessory and dorsoscapular nerve entrapment can be a cause of upper back and neck pain. You can see the picture of the spinal accessory nerve, like coming out of the jugular foramen and coming downward to the back of the neck. And similarly, the course of dorsoscapular nerve is also seen nicely in the picture, which is along near to the medial border of the scapula. So starting with spinal accessory nerve, the spinal accessory nerve is typically it is considered a motor nerve, and it has a dual origin. As you can see in the picture in the upper part, it has a cranial root which arises from the nucleus ambiguous of the brainstem, and it also has a spinal root which arises from the spinal accessory nucleus located in the cervical anterolateral aspect of the cervical part of the spinal cord. And these two nerves unite just before it exits out through the foramen, jugular foramen, and immediately after exiting out from the jugular foramen, again the cranial nerve and the spinal nerve separates. Okay, the cranial branch basically it merges with vagus nerve and innervate soft palate, larynx, and pharynx, whereas the spinal branch basically descends downward and and posteriorly and downwards, and it emerges or it exits from the posterior border of sternocleidomastoid and reaches down and supplies to the trapezius muscle. So as you can see in the picture, the spinal accessory nerve basically supplies two muscle. Anteriorly, it supplies the sternocleidomastoid muscle, and posteriorly, it supplies the upper part of the trapezius muscle. So entrapment of this muscle is very much common, especially if there is any problem associated with a muscular hypertrophy, or the entrapment of spinal accessory nerve can be there, or if the trapezius is one of the most common cause of myofascial pain, and in these conditions also we can block the spinal accessory nerve to relieve the upper back and neck problem. So similarly, dorsal scapular nerve is also mainly a motor nerve, and it arises mainly from ventral rami of C5 spinal nerve root as a uppermost branch of the brachial plexus. In 75% of cases, it arises from C5's ventral rami of C5 spinal nerve root, but in remaining 25% of cases, it can arise from C4 or T1, this ventral rami of C4 or T1 spinal nerve. And as soon as it emerges into the interscalene triangle, it immediately pierces the scalene medius muscle, and it courses downward and behind the brachial plexus, and it supplies to the levator scapulae muscle, as well as it also supplies the rhomboid major and minor muscles. So entrapment of dorsal scapular nerve is also common. So if there is entrapment of dorsal scapular nerve, there is basically lateral winging of the scapula, and we can check the lateral winging of the scapula by asking the patient to elevate the arm over the head. And when we do this, then there is a lateral winging of scapula if there is any palsy of or entrapment of the dorsal scapular nerve. So normally indication for the SADS block, which is also known as SATS block, which indicates spinal accessory and dorsal scapular nerve block. Normally, it is done in myofascial pain syndrome involving trapezius, levator scapulae, as well as rhomboid muscle. It is also done during if there is entrapment of the spinal accessory as well as dorsal scapulary nerve, or if there is a vague pain in the interscapular pain between the medial border of two scapulae muscle, then also we are doing the SATS block regularly and routinely in our clinical practice. So to do the spinal accessory and dorsal scapular nerve block, normally the position of the patient is prone, as shown in this picture, and we choose the linear probe and like this. Okay, so normally what we do is at the beginning, we put the probe in a horizontal manner just over the upper part of the neck, so that the lateral most footprint of the linear probe is over the medial border of the scapula, upper medial border of the scapula. And when we put the probe in the position like this, in the horizontally, in the between the neck and the upper part of the back, with a small part of footprint overlying the medial aspect of the scapula, we can see this typical picture. You have also seen this picture while sir has already demonstrated nicely. Here we can see a medial border, upper medial border of the scapula, and over that is the trapezius muscle, and you can distinctly see three basically layers of muscle. The uppermost muscle is trapezius muscle, and the middle layer is basically rhomboid major and minor, along with levator scapulae muscle, and the deepest muscle is serratus posterior muscle. And between the layer 1 and layer 2, you can see spinal accessory nerve as highlighted by the red circle, and below it you'll be seeing the dorsal scapular nerve between the layer 2 and layer 3. Usually both of the nerves are accompanied by the artery. The spinal accessory nerve is accompanied by transverse cervical artery located in between the first layer trapezius and second layer rhomboid major, minor, and levator scapulae. Similarly, the dorsal scapulary nerve is accompanied by dorsal scapular artery, and it is between the second and third layer. That is, the second layer is rhomboid major, as well as minor and levator scapulae, and the third layer is serratus posterior muscle. So once we get this view, then we turn the probe 90-degree. So as to get the sagittal view. And in this sagittal view also, you can see nicely here, you can see that the probe has been turned so as to get the sagittal view of all three muscles. And if we turn this probe in the 90-degree like this, we'll be able to see these three layers of the muscle. The upper one is trapezius, middle one is rhomboid and levator scapulae, and the lowermost one is the serratus posterior muscle. And you can nicely see the spinal accessory nerve between the trapezius first and second layer, and dorsal scapular nerve between the second and third layer. And once we get this view, then a needle is injected in the in-plane manner from caudal to cranial or cranial to caudal direction. And we basically reach the interfacial plane between the second and third, or first or second, and block this nerve by using a 5% dextrose, or we can also use lignocaine with steroid to block these nerves. So this is the picture of the SATS block. Here, the left side picture shows the needle in the in-plane direction from cranial to caudal direction, and as you can see, the nerve is indicated with the blue color marking between the trapezius and the levator scapulae and rhomboid. So this is the area of blockade for the spinal accessory nerve. And if we further push our needle downwards in the same axis and if we put the needle between the second and third layer, that is the rhomboid and levator scapulae in above, and below is the serratus posterior superior, then this is the area for the blockade of the dorsal scapular nerve. This is also known as 5-in-1 block, because we can inject 5 different things in the same with one single needle injection. The 5 different things are 3 muscles we can do trigger point injection. One is trapezius, another is levator scapulae, and another is rhomboid major and minor. So these are the 3 muscles, and 2 nerves we can block with a single injection. That is the superficial one is the spinal accessory nerve, and the deeper one is the dorsal scapulary nerve. So SATS block will be publishing most probably in the next edition of musculoskeletal ultrasound on pain medicine from Dardia, the pain clinic. So, and this is the typical way of blocking all 3 muscles as well as 2 nerve with a single prick of injection. So second is intercostal nerve block. So intercostal nerve block is also commonly done, and we'll be seeing the indication for various indication for intercostal nerve block. So these intercostal nerve arises from the 12 pairs of thoracic spinal nerves, and as the thoracic spinal nerves exits from the intervertebral foramen, they divide into ventral and dorsal rami. So ventral rami of the thoracic spinal nerves basically continues in front as a intercostal nerve, and it enters into the this intercostal space or intercostal groove. Okay, so the upper from number T1 to T11 forms basically intercostal nerve, and the last one T12 basically forms the subcostal nerve, and it basically unites with L1 ventral rami of L1 spinal nerve to form the iliohypogastric and ilioinguinal nerve. So typically these intercostal nerve are located in the intercostal groove as shown in this picture, which is usually accompanied by intercostal artery and intercostal vein, and it is located in between 2 muscle plane. So the innermost is the innermost intercostal muscle, and just behind that is the internal intercostal muscle. So in between the internal intercostal muscle and innermost intercostal muscle is the location of the intercostal nerve along with its neurovascular bundle. And the most in the most upper part is the intercostal vein, which is followed by the intercostal artery, and the lowermost part is the intercostal nerve. So normally the intercostal nerve is the mixed nerve. It contains like the sensory fibers, dorsal horn sensory fibers. It also contains ventral horn motor fibers and some element of post-ganglion sympathetic nerve. And basically these intercostal nerve again divides into, it gives lateral cutaneous branches as well as anterior cutaneous branches. Okay, so this is the picture of the location of the intercostal nerve as well as neurovascular bundle. As you can see, the intercostal artery arises from descending thoracic aorta, and intercostal vein arises from azygous vein and hemiazygous vein, and lowermost part is the location of the intercostal nerve, and it is located in between the innermost intercostal muscle and internal intercostal muscle. So in the groove of intercostal groove, and these nerves are located. And in the right side of the picture, you can see how the thoracic spinal nerve is formed in the intervertebral foramen. After the formation of the thoracic spinal nerve, it basically divides into ventral rami and dorsal rami. The ventral rami continues forward as an intercostal nerve in the intercostal groove and supplies to the skin and muscles in the specific segment. And you can also see the lateral cutaneous branch as well as anterior cutaneous branch of the intercostal muscle. Okay. So this is also a picture, schematic picture as well as ultrasound picture of the location of the intercostal nerve. Here you can see between the innermost intercostal muscle, which is the deepest one, and just superficial to it is the internal intercostal muscle, and in between these two muscle is the location of intercostal neurovascular bundle, where the nerve is most inferior. Just above the nerve is intercostal artery, and most above is the intercostal vein. So, and this is the ultrasound picture. In the right side is the ultrasound picture of the location of the intercostal nerve. As you can see, this is the sagittal view, where you can see two ribs, hyperechoic structures are the two ribs, and in between the two ribs is the window. In this window, we can see the outermost layer is the external intercostal muscle. Just below this external intercostal muscle is the internal intercostal muscle, and below the internal intercostal muscle is the location of the near the intercostal groove is the location of the intercostal nerve. And unfortunately, the innermost intercostal muscle is not nicely seen, but you can nicely see the hyperechoic glittering pleura. So our needle, the location of intercostal nerve has been here. The asterisk mark has been given at the site of the location of the intercostal nerve, and we basically do the injection in the in-plane manner from the inferior aspect of the rib towards the target area, just in the groove of the intercostal groove, above the pleura and innermost intercostal muscle. So these are the various indication of the intercostal nerve block. We regularly do intercostal nerve block in case of intercostal neuralgia, in case of chest wall surgery to post-operative pain relief. We also do intercostal nerve block if there is any fracture of rib or chest wall trauma. It is regularly done if the pharmacotherapy is not helping in case of post-operative neuralgia. So the specific dermatome, the post-operative neuralgia which is involved, we basically go and block the intercostal nerve block with local and steroid, or we can also do cryoablation in this area. So regarding the sonoanatomy, the position of the patient can be sitting, the patient can be prone or lateral decubitus. We usually choose a high frequency linear probe to block the intercostal nerve, and normally the desired intercostal nerve level has to be found out. You can basically determine the level of the intercostal nerve that is to be blocked by using various anatomical landmark. For example, you can use the spine of scapula level, which basically indicates the spinal process of thoracic fourth vertebra. We can also choose the inferior angle of the scapula, which basically denotes thoracic 7 spinous process, Or you can see, go and palpate the middle part of the upper part of the neck, where you can see two bony projection. One is C7 spinous process, another is T1 spinous process. The difference between the C7 and T1 spinous process is that T1 spinous process is usually fixed, regardless of movement of the neck. The spinous process, T1 spinous process, will not move, but the C1 spinous process will move as we rotate or flex the neck. So these are the few anatomical landmarks for you to guide the level of the intercostal, to get the level of the thoracic level, and by this we can calculate the level of the intercostal nerve that is to be blocked, and we can put our ultrasound over the area and then easily block the intercostal nerve. So regarding the procedure for blockage of intercostal nerve, normally we can put the probe in the sagittal axis, which is parallel to the posterior mid-clavicular line. This basically is at the angle of the rib, and when we put our probe in the sagittal axis, in the posterior mid-clavicular line, we can typically see the picture that is shown in the slide. So this picture is between the 6th and 7th rib. You can see a cross-section view of 6th and 7th rib, and in between the 6th and 7th rib cross-section, you can see the window through which the glittering pleura, we can easily see the glittering pleura. And in between these two ribs, there is a layer of external intercostal muscle, which is more superficial. A bit deep to it is the internal intercostal muscle, and the deepest one is the pleura as well as innermost intercostal muscle. And the location of the intercostal nerve is denoted by the asterisk in this picture. And to block the intercostal nerve, basically we put the needle in plane manner, because if we put the outer plane can be a bit dangerous in this position, because we tend to go more, if we tend to go more deeper, we can easily puncture the pleura and get the pneumothorax. So in plane approach from caudal to cranial direction is usually preferred to block the intercostal nerve. Normally the site of puncture is usually the superior border of the inferior rib. So if I want to block the 6th intercostal nerve, then my site of needle entry point is the superior border of the lower rib, that is 7th rib. Superior border of the 7th rib will be the site of my needle injection, and from here at that angle of 35 to 45 degree, the needle is targeted towards the lower portion of the above rib, just above the pleura and innermost intercostal muscle. And in this area, we can deposit the local anesthetic with steroid, or we can do radiofrequency, pulse radiofrequency, and ablate the nerve. And normally, basically, we will not be able to visualize the innermost intercostal nerve. So basically, we tend to rely on spread of drug between the internal intercostal muscle and pleura. This is how we will be blocking the internal intercostal muscle. And here in the lower part of the picture, I've shown you the red mark is basically the direction of the needle. And as you can see, the needle is the puncture site of the needle is above the lower rib, superior border of the lower rib. So we puncture the superior, the site of puncture is the skin at the superior border of the lower rib, and the direction of needle is towards the upper, the inferior border of the upper rib. Okay, and at the angle of 35 to 45 degree, and the needle end point of the needle is above the pleura and innermost intercostal muscle, just below the desired rib, which we have to block. So after completion of the block, it is advised to auscultate the lung just to check whether there is pneumothorax or not. Normally, if you do under the guidance of ultrasound, normally there is no incidence of pneumothorax, but it is always good to check whether there is pneumothorax or not. And you can also check the pneumothorax with using ultrasound. If you put the ultrasound probe in between the two ribs, and you can easily see the pleura as well as hyperechoic pleura as well as seesaw sign in the B mode of ultrasound. So this is the seesaw sign in B mode of ultrasound. When to when we are looking through the window between the sixth and seventh rib. You can easily see the glittering pleura. Okay, so this is the glittering pleura, and we can see the seesaw sign. So if there is a seesaw sign is present, then we are safe. If the gliding of pleura is absent, or if the seesaw sign is absent, then there might be incidence of pneumothorax, which should be checked after doing the intercostal nerve block. So another block that we commonly do is erector spiny plane block. As Sir has rightfully said, it is not only done for a post-operative pain management in anesthesia. We are doing erector spine plane block if there is a wide area of muscle pain in the thorax and lower back. It was first done by Forero et al. In 2016 for the indication of thoracic neuropathic pain, which was secondary to the thoracic surgery, as well as for metastasis, and it was initially done to relieve pain from painful malunion of rib. But nowadays, the indication of erector spiny plane block has been widened. It is usually done to decrease acute or chronic pain syndrome of thoraco-abdominal region, and it is also done to give analgesia of brachial as well as lumbar plexus. So this erector spiny plane block can be done from neck to the lumbar area, as because the whole of the spine from neck to the lumbar area is we can easily identify the erector spiny group of muscle, and simply by injecting drug at the anterior most or deeper most part of the erector spiny muscle and tip of transversus, we can block a wider area of the region of abdomen, of the thorax, abdomen, or in the lumbar area. Okay. So yeah, this is the picture of where we can see the diagrammatic picture of the placement of needle. You can see the needle is placed just over the tip of the transverse process, and you can also see the spread of drug above in the cranial direction, in the caudal direction. The drug can even go into the intervertebral foramen and in the epidural space. Okay, here there is an MRI picture of the spread of drug and the dye when the erector spiny block has been done. So the left side of the MRI picture is basically the foraminal view, sagittal plane in the foraminal view. You can see the white color drug has been spread along the whole area of the erector spiny muscle plane, and you can also see the drug into the intervertebral foramen as indicated by the yellow arrow. So that means if we deposited the drug in this erector spiny plane block, the drug can slip into the intervertebral foramen, and even it can go into the epidural space. So this picture B is basically the sagittal view at the mid part of the spine. Here you can see the white color contrast spread in the epidural space as well, in addition to this erector spiny plane muscle plane. So this means the drug has slipped into the intervertebral foramen and epidural space. And this is the axial view. You can see in axial view nicely spread of drug along the whole of the various muscle plane of the erector spiny muscle. The drug is also spreading into the intervertebral foramen and in the epidural space. So wider area of the pain area coverage can be done with erector spiny muscle plane block, and it is commonly used both for acute as well as chronic pain management. So the target of the needle placement, as you have already seen, as demonstrated by Sir, here the target is between the tip of the transverse process and anterior and deeper most layer of the erector spiny muscle. As shown in this picture, you can see the needle is at the junction between the tip of the transverse process and the anterior and deeper most part of the erector spiny muscle. And when we deposit the drug here, the drug can easily spread to the cranially as well as caudally, and it is said that the average the spread of drug is usually 6 spinal segment, but we have to use larger volume of drug. We are usually using 20 to 30 ml of drug, which usually spread above and below the whole of the fascia of the erector spiny muscle. And not only that, it also the drug will also go into the intervertebral foramen and block the ventral and dorsal rami and sympathetic anesthetic ramus, and it also goes into the epidural space if larger volume of drug is used. And because we are using larger volume of drug with low concentration of local anesthetic agent, so this low concentration of local anesthetic agent will block only A delta fibers and C fibers. So it will be able to block the sensory fibers, but motor fibers will not be affected. So this is the beauty of the erector spinae muscle block. So there are various levels of level that we can block depending upon our choice of our need of our blockade. So we can go for high thoracic block. If you are targeting T2 or T3 transverse process, we'll be blocking the higher thoracic block, which is usually used to relieve the shoulder pain, because it also blocks the brachial plexus, some of the fibers of the brachial plexus. And we usually use larger volume of drug, that is, we usually use 20 cc of drug to block this. Similarly, mid thoracic block can be used when we place the drug between T4 to T6 tip of transverse process. It is usually done if there is any painful refracture. It can be used for thoracotomy surgery, lobectomy, sternotomy, cardiac surgery. It is commonly done in the cardiac surgery for postoperative pain management. Similarly, breast surgery. Chronic post-herpetic neuralgia, we are also using this block, as well as in metastatic rib cancer pain management. Also, we can use this erector spinae plane block in the mid-thoracic region between T4 to T6. Similarly, we can also block at the lower thoracic level between T7 to T12, and there are various indication has been listed in this slide, such as nephrectomy, hysterectomy, for the pain management, for laparoscopic ventral hernia repair. In case of chronic abdominal pain syndrome, also we can use this block. In case of chronic pelvic pain, we can also use this block, as well as in chronic post-herpetic neuralgia also we can use this block at the lower thoracic segment between T7 to T12. Similarly, we can use this block in the lumbar area also for management of post-surgical hip replacement pain management. So this is the list of the various indication for the erector spinae plane block. As you can see, high thoracic level blockade can also be done. We can go for mid thoracic level. We can block the lower thoracic level as well as lumbar region for the various condition that is listed in this slide. Okay, so we can go for unilateral as well as bilateral block, but high thoracic erector spinae block is usually recommended to do unilateral instead of bilateral. In other rest of the area, we can go for unilateral or bilateral block, and typically we are using larger volume of drugs, that is about 20 cc of drug of low concentration of local anesthetic agent is used for the blockade. And as you can see in the picture here you can see the extension of erector spinae muscle from the neck to the sacrum. So we can use upper thoracic, mid thoracic, or lower thoracic, or even the lumbar area to do this erector spinae plane block and achieve excellent analgesia for acute as well as chronic pain management. This is the ultrasound scanning for the blockade of erector spinae plane block. Normally, the position of the patient can be either sitting or lateral or in prone position. We usually use linear probe, or we can also sometimes use curvilinear probe if the patient is slightly obese or if the patient has a high BMI. We can identify the transverse tip of the transverse process by two methods. One is by using the transverse view, and another is by using the sagittal view. So both of the views has been nicely demonstrated by the sir. I will basically be repeating the same thing. So normally at the level of the desired level of blockade, we'll put the curvilinear or linear probe in the transverse view manner. And we can, if we put the probe in the transverse view at the desired level, we can identify the spine of the vertebra. We can also identify the bulk of the erector spinae muscle overlying the lamina and the transverse process. So this is the ultrasound picture of the transverse view over the mid part of the thorax. You can see the transverse process as well as the lamina and a spinous process, lamina as well as transverse process as well as rib. So you can see a big chunk of erector spinae muscle over the lamina and transverse process. And when we achieve this, we can rotate the probe in 90 degrees to get the sagittal view of the transverse process. So once we get the sagittal view of the transverse process, we can easily insert the needle in plane direction from cranial to caudal or caudal to cranial direction. And you can see here the needle is placed just over the tip of the transverse process below the anterior or deeper most part of the erector spinae muscle. And in this area, we have to flood this area with 20 to 30 cc of the low concentration local anesthetic agent, which will be blocking a wider area of the desired area that needs to be blocked. So this is one of the technique to block the erector spinae plane block. Another technique is we can go from the rib and we can, in the sagittal view in the rib, and we can gradually move this probe more to the midline. And once we get the tip of the transverse process, we can inject the drug in an in-plane manner, which has been explained by the sir. Here I want to focus that. See the sonoanatomy of spine and the transverse process. Here in the upper part, we can put the probe in the sagittal view and see the rib. So here you can see the rib is rounded structure, and you can see the pleura in between, hyperechoic pleura in between the rib. Once we get this picture, you can gradually slide the probe more to the medial side, and gradually the orientation of this hyperechoic rib will change into more square shaped structure. So once we get more square shaped structure, then we know that we are over the transverse process. And here it is very difficult to get the pleura. Over the rib, you can easily see the pleura, and we can identify that this is the rib, rounded hyperechoic structure, followed by hyperechoic glittering pleura can be seen at the level of rib. But if we move our probe more medially, and if our the probe is over the transverse process, then this circular or round shaped hyperechoic structure will change into more box-like or square-shaped structure, and there will be absence of pleura below it. So at this area, basically it is the area of the tip of the transverse process or the transverse process. And here we can insert the needle in plane direction, either from cranial to caudal side or caudal to cranial side, and deposit the drug over the transverse process anterior to the erector spinae group of muscles. So here also I have included the picture. The placement of needle is just over the tip of the transverse process, deep to the erector spinae plane block. Here we can also use catheter in this area, put the catheter and go for a long-term pain management by depositing the local anesthetic continuously in this area. So here you can easily see the in-plane direction of the needle below the erector spinae muscle and behind the tip of the transverse process. This is the typical way how we do the erector spinae plane block to achieve acute and chronic pain management. So coming to the lumbar medial branches block and facet block. So we know that low back pain is one of the most common cause of disability worldwide. And it is there is no statistical data in our part of the world, but in USA, it is said that the incidence of chronic low back pain is about 19 to 20%, and in the industrialized nation, the incidence of chronic low back pain is about 13 to 28%. So the low back pain can be of multiple factors. It can be from the nerve root, or it can be from the muscles of the low back, or it can be from the intervertebral discs or from the facet joint. But facet joint are arthropathy is one of the most common cause of low back pain, and it contributes to the chronic low back pain to about 25 to 45%. So in the clinic, we'll be seeing lots of pain with the low back pain, where it might be facetogenic in origin. So if you see the anatomy of the facet joint, lumbar facet joint. So lumbar facet joint is basically a small synovial joint with volume of 1 to 1.5 ml, and each of the facet joint is basically supplied by the dual nerve innervation from the medial branch of the dorsal rami of the same vertebra as well as one vertebra above. So if you consider, if you see this picture, and if you focus on L2 and L3 facet joint, and as you can see, this L2 and L3 facet joint receives nerve supply from the L1. This is the L1. So this is the dorsal rami of the L1 spinal nerve, and you can see this is the medial branch of the dorsal rami, medial branch of dorsal rami of L1. You can see this is gradually coming down, and one of the branches it is giving is to the L2 3 facet joint. Similarly, this L2 facet joint, 2-3 facet joint also receives nerve supply from the medial branch of dorsal rami of L2, this lumbar spinal nerve. So this facet joint receives nerve supply from the same vertebra as well as the vertebra above, but the level of blockade is at the L2 and L3, the group between the superior articular process and transverse process. This is very important. Okay, so if you have to put the needle, we have to put the needle in two different places. At the if you are blocking L2-3 facet joint, if you are blocking the medial branch, the needle position is at the level of L2 and at the level of L3, but the nerve supply is from L1 and L2. So this can be asked commonly in your multiple choice question. So you always have to remember there is a dual nerve supply. Nerve comes from one level above and from the same level, but the blockade is at the same level. So if you are blocking L2-3 facet joint, needle placement is at the level of L2 and at the level of L3. But the nerve supply, the nerve that we are blocking is actually medial branch of dorsal rami of L1 and medial branch of dorsal rami of L2. So with this knowledge, let's go to the clinical presentation. Normally, if the patient is having low back pain and if it's a facetogenic origin, the diagnosis is usually clinical and there is no radiological test. Usually, we can see sometimes in MRI the arthropathy of the facet joint, but in normal X-ray, we'll not be able to find out the pathology in the facet joint. So normally, the diagnosis of low back pain, which is facetogenic origin, is usually clinical diagnosis, and we can also give diagnostic medial branch block or diagnostic facet block and see the improvement of pain and the movement, which is also one of the diagnostic tests for the facet joint arthropathy. Typically, when the a patient with facetogenic origin back pain comes, the patient usually complains of unilateral or bilateral low back pain, and low back pain is usually aggravated in sitting to standing position or when the patient tries to climb up the stairs, and there can be referred pain, non-dermatological referred pain to the flank, hip, or lateral aspect of the thigh, usually above the knee. But sometimes rarely, but sometimes the radiation of pain can go below the knee up to the foot. And normally when we do the test, extension and extension loading test is positive. If you palpate the back, paramedian tenderness over the facet which is causing problem will be tender. Normally the special tests such as favor, fair, and straight leg rising test will be negative, and motor, sensory, and reflex of the patient will usually be preserved in these conditions. So you can see in this picture back pain, and this is a non-dermatological referred pain pain. Usually referred pain is above the knee joint, but sometimes in the rare cases it can go beyond the knee up to the foot. And most commonly the referred pain is over the flank, over the hip, in the gluteal area, as well as in the lateral aspect of thigh. And sometimes the pain can even radiate to the groin area of the patient. So to scan the medial branch and the facet joint, where usually the patient position is usually prone, and we usually use curvilinear probe, like sir has demonstrated in the lumbar area. There are basically 5 basic views in the lumbar area which we should be knowing. First one is paramedian sagittal transverse process view. Second is paramedian sagittal articular process view, where we can see a camel hump sign, and another is paramedian sagittal oblique view. This oblique view is required to go to the intrathecal space. In this paramedial sagittal oblique view, we can nicely see the anterior dural complex, the posterior dural complex, and we can also give epidural injection in this view. And 2 other views are transverse spinous process view and transverse interlaminar view. So this is the typical picture of the paramedian sagittal transverse process view. You can see the orientation of the probe is in the sagittal view, just over the transverse process. And as you have already seen the live demonstration of the sir, when in this view you can see this is also known as trident sign, where you can see posterior acoustic bony shadow of the from the transverse process is seen, and above the transverse process is erector spiny group of muscle, and below the transverse process is usually the psoas muscle, and you can also see peritoneum and the abdominal content. So this is the paramedian sagittal transverse process view, where the probe is just over the transverse process in the sagittal manner, and this is the orientation of the probe over the transverse process. And you can this posterior acoustic bony shadow, you can also call this as a trident sign. So another view is this paramedian sagittal articular process view. Here you can see the orientation of the probe, and the probe is placed in the sagittal axis over the articular process, and here you can see these hump, and this is known as camel hump sign. Here there is the bony mark, the mark is continuous there, so hyperechoic bony line is continuous, so there is no gap in this view. But if we just tilt this probe more oblique towards the medial aspect, we can see the this intrathecal space with anterior and posterior dural complex. Okay, so this is basically a simple paramedial sagittal articular process view. So if we just tilt the probe more medially in the same view, we can see the lamina of the spine. This is the horse head sign, and between the 2 horse head sign bony structure, we can see this is the window through which we can see anterior dural complex. We can also see posterior dural complex. We can see epidural space and the ligamentum flavum. Okay, so which is marked with the asterisk. So with this, by tilting the probe slightly to the medial aspect in the paramedian sagittal articular process view, we can get this paramedian sagittal oblique view. And in this view, nicely we can see intrathecal space as well as anterior complex, which sir has already shown, which consists of posterior longitudinal ligament, vertebral body, and anterior dura. We can also see posterior dura. In between the posterior dura and ligamentum flavum, we can see epidural space. And in the difficult epidural anesthesia, we can use this view and put the needle in between the ligamentum flavum and posterior dura, or even put the catheter in this area for the epidural anesthesia. So the other view is the transverse spinous process view. Here you can, if you see, now the probe is placed in the transverse manner over the spinous process of the lumbar spine. So when we put the probe in the transverse manner over the spinous process, you can see the spinous process. On both sides of the spinous process, you can see erector spiny group of muscle. You can also see the lamina as well as the transverse process. So this is the transverse spinous process view. And if we just slide the probe more downward or upwards at the level of in between the two spinous process, and this is called transverse interligamental view. So here we are viewing into the spinal canal through the interspinous ligament and supraspinous ligament. So here we can see the interspinous ligament. This is not the spinous process, but this is the interspinous ligament, and through the interspinous ligament we can see nicely see the anterior dural complex. We can see the posterior dural complex. In this view we can also see the inferior articular process medially. We can also see superior articular process laterally and the transverse process. So this is the bat wing sign. So here we can block the medial branch between the superior articular process and transverse process. If we put our needle in an in-plane manner between at the junction between the superior articular process and transverse process, if we put our needle here, and if you see the arterial pulsation in this area, we can easily block the medial branch for the facetogenic pain. So this is the transverse interligamental view for viewing the interthecal space, as well as to block the medial branches of for the facet joint arthropathy. So normally, if you are blocking the medial branch for facet joint arthropathy, we have to know the level of vertebral level to which it should be blocked. We're using CM. It is very easy to identify the various level to be blocked, but we can use ultrasound also to count the vertebral level at which these block has to be done. So there are two ways to count the vertebral level. One is sagittal view and another is the transverse view. So initially with the sagittal view, we can put the probe as shown in this picture in the sagittal manner over the transverse process, and we can also put in such a manner that lower part of the probe is just over the sacral ala. So when we do this, we can easily count the sacral ala. We can also easily see the transverse process as shown in this red mark. You can see the lowermost part is the sacral ala. Just above the sacral ala is the transverse process of fifth lumbar transverse process, and above it is the fourth lumbar transverse process. So while doing this, we can go above and count the transverse process, and then go into the spine and count the vertebral level. This is one of the way, and another way is we can start this from more medially. So more medially means over the lamina. We can also put the probe in a sagittal view. Especially this is called paramedial sagittal oblique or the laminal view. We can also say that. Here also we can easily see the lower part of the sacrum, and we can see the horse head sign of the lamina, and we can count the horse head of these lamina and go above and block the and reach the desired lumbar vertebral level which is to be blocked. And in this view, especially the paramedial sagittal oblique view, you can also see anterior and posterior dural complex as shown in this picture. So the upper right part is the paramedial sagittal oblique view, which can be used to count the vertebral level. Here you can see the right lateralmost area is the sacral area, and above it is this is the head horse. These are the lamina of the lumbar spine, and between this lamina you can see the interthecal space as indicated with this hyperechoic structure and the anterior and posterior dural complex. This is one of the way. Another is go more laterally at the level of transverse process, and we put the probe just in the sagittal view just over the transverse process, and you can easily see finger-like projection, and the lowermost finger-like projection is the sacral ala, and above it is the lumbar 5 transverse process, and above it is the lumbar 4 transverse process. So this is how we can count the level of the lumbar vertebra which needs to be blocked. But sometimes if there is any sacralization of the lumbar spine, or if there is any lumbarization of the lumbar spine, this can be a bit more difficult in these conditions. in which we have to go for a fluoroscope or X-ray to determine the level. So this counting can be wrong when there is lumbarization of or sacralization of the lumbar vertebra. So another way to count the lumbar vertebral level is by using the transverse view. Here we have to put the probe transversely over the sacral upper part of the sacrum, and if we put the probe just transversely over the upper part of the sacrum, you can nicely see the medial sacral crest at the level of posterior superior iliac spine, like sir has nicely demonstrated. So this is the medial sacral crest, which can be easily seen when we put the probe transversely over the upper part of the sacrum. And if we move the probe slightly above or slightly cranially, then suddenly this medial sacral crest will vanish, and we can easily see the intrathecal component, like we can see the dura, posterior dura and anterior dura. So this is the transverse interligamental view at the level of L5S1. So if we gradually move our probe more further in the cranial region, then we can go for the transverse spinous process view. So this is the spinous process of the L5 lumbar spine. So this is the another way to count the lumbar vertebra. So we can count the lumbar vertebra using the transverse view, as well as we can go for the sagittal view and also count the lumbar vertebra, and we can reach the desired level of lumbar vertebral body in which median branch block or facet block can be done. Okay, so to do the lumbar median branch block, it is after counting the desired level of lumbar median branch block that is to be done, we usually put the probe in the transverse axis. And then we basically we try to see the spinous process and the transverse process. So once we get the in the middle, first we put the probe in the transverse plane at the desired level and see the transverse process and as well as the superior articular process, and then the needle entry point, the end point of the needle is basically at the junction between the transverse process and superior articular process. And in this way we put the needle in the in plane manner from lateral to medial aspect at the junction between the tip of the transverse process and the superior articular process. Here you can nicely see the needle coming from lateral to medial aspect at the junction between the this transverse process and the superior articular process. And we can confirm the needle position by rotating the probe to 90 degree. And when we rotate the probe to 90 degree in this position, we can see this is basically a paramedian transverse process view. You can see easily the transverse process like finger-like projection, and our needle should be at the over the transverse process near to the cephalad edge of the transverse process. So this is the end point of the needle placement for the median branch block. To relieve the facet joint problem, we have to block this median branch at two levels, one level above, same level, and one level above, to effectively block the medial branch to achieve the to relieve the facet pain in case of chronic low back pain secondary to the facet joint arthropathy. Okay, thank you. So this is the total presentation, sir, today. Hello.
Yes, Siri.
Okay, sir. So these are the slides that I've included for today's presentation, sir.
Yes,
but
it
there are
was
lots
an
of
elaborate presentation. So, thank you very much. And everybody has enjoyed also the musculoskeletal total class also. As I told that over the next 2 weeks time, you will be having the exam link will be available from tomorrow. If you are going to the website means your series, you can stop sharing.
yes.
If you are going to the website, means the learnpain.org /pain medicine courses and login, you'll be getting the exam link, and in the exam link that will be activated tomorrow, and you can go ahead with the exam. I'll be asking the Sanjeev to share how to give the exam also. It is very simple, but it is mentioned there, it will be exam link will be available for 1 month, but it is not 1 month, it will be available only for 2 weeks. Means it will be available, today is 5th. So it will be available till your 19th, sorry. 5th plus tomorrow is 6th. Okay. Till 20th, the exam will be available. And also all the videos also will be available till then. And you have to complete the exam. Thank you very much. Any questions?
Sir, other than the video content, do we have to read anything extra for the exam?
No, if you are going through the video only, it will be enough, more than enough. Most of these questions are basically the anatomy, sonanatomy questions are there. Details of the pathology we have not asked, because that is the basic thing about the MSK ultrasound. The most important part to learn is your anatomy and sonanatomy. So questions are basically on that. Apart from that, few more questions was there. And but everything is very easy, very simple, no negative marking. I hope everybody will be clearing it. There should not be any, nothing to be anxious. Okay, thank you very much. But this your group in the WhatsApp will not be dissolved. So we'll be posting some of the new videos that will be there. We'll be posting there so that you can go and continue. And also, I hope that everybody is a subscriber of the Darodia YouTube channel, Darodia Pen Clinic. So there also a lot of materials are there, and in the future also a lot of material will be added. So go on reading, go on enjoying. As I was telling, musculoskeletal ultrasound is difficult for the beginners. More and more you scan, more and more you'll be learning. So thank you very much and good night for today.